Thank you very much for the privilege to be part of this exciting meeting, and I'm really excited to be here with such a team of people that are very together on trying to find better treatments for LGS. So I'm going to be talking about how we currently manage LGS in children and identify areas where we may fall short. So here are the objectives. First of all, how well can we predict which child will actually evolve to LGS? And if we can predict that, how successfully can we actually intervene to prevent that evolution? Secondly, what is the current state-of-the-art therapy for established LGS, and how successful are those treatments, both for seizure control and comorbidities? And then finally, where do we actually need to improve? So Tracy had already alluded to this. So in 2022, the ILAE came down with a definition of LGS, and we now understand that that is multiple seizure types, one of which must be tonic seizures. An EEG, which shows both generalized slow spike wave as well as generalized paroxysmal fast activity, and recognizing in adulthood the generalized slow spike wave may no longer be present. And the age of onset in the pediatric years, and the long-term outcome, as you all know, drug-resistant epilepsy and variable degrees of intellectual disability. But what is also important is most people don't suddenly develop LGS. This is something that evolves from another type of epilepsy. And so the ILAE recognized that by calling it a syndrome in evolution, and noting that particularly with early infantile DEEs, such as infantile epileptic spasms, up to 50% of those babies may go on to develop LGS with time. This was looked at nicely by Anne Berg, and she assessed evolution in a cohort of infants with DEE. And at initial diagnosis, only 4 of 58 infants who had DEE, in fact, were diagnosed with LGS. But over time, 22 of 58 ultimately developed that. So we see that a lot of these babies develop that over time. And she found that evolution took a median of 1.9 years. And so that's a challenge because, again, as we've heard, there are certain medications approved for LGS, but you need the diagnosis. So how well can we actually predict this? This was a study from Colorado looking at almost 100 infants with spasms over a 6-year period, and they found a third of them went on to LGS. And they did find some pretty good predictors. So developmental delay, history of prior seizure types, poor response to first spasm treatment, known etiology, and you can see these are pretty nice p-values. But in red are the proportion of patients who had those that went on to develop spasms. It's almost as good as flipping a coin, okay? So it's really not very helpful. Well, how about EEG? And we're going to hear a little bit, I think, tomorrow from Jennifer on this. And it's already been recognized that seeing slow spike wave may be a predictor. But importantly, this was a study looking at patients who evolved from infantile spasms to LGS. And you can see a fair number of those children actually did not have slow spike wave. So again, not a terribly robust predictor. So I think we can identify infants who have or who are at possible risk, but we really lack clear biomarkers to predict this evolution with high degrees of certainty. And if we have a preventative medication, we're going to need better than 50%. So even if we can predict, can we intervene effectively? And right now we have no evidence that any of our anti-seizure medications, steroids, dietary therapies can actually prevent this outcome. But there have been some cases where early surgery can. And this is, you've already heard about the interesting work done out of Australia looking at network analysis in LGS. And typically what we see in neurotypical individuals, I'm just going to see if that doesn't work. Typically what we see in neurotypical individuals is over on the far side where we see a lot of positive within network connectivity and negative between network connectivity. In LGS, we actually lose that pattern, and that probably explains why many patients with LGS do have cognitive challenges as well. What this was a report of a single patient who underwent epilepsy surgery, resective epilepsy surgery early on, and recognized that most of our LGS patients are not going to have a focal lesion that will allow this, but if they do, it's really important. And we can see here pre-surgically, his connectivity analysis looks very similar to other patients with LGS. But post-operatively, he actually had normalization of that connectivity analysis, and he did very well. So what about current state-of-the-art for seizure control? And we have a number of different current state-of-the-art proposals. This is by Stefano Venn and colleagues, really looking at what medications we use and what is the place of non-pharmacological therapies. We see valproate is considered first line, lamotrigine, rufinamide next, and then clobazam, cannabidiol, felbamate, topiramate, fenfluramine later on. And then other non-pharmacologic therapies, dietary therapies, neuromodulation, surgeries, corpus callosotomy, these all should fit in early consideration, but can be used at any time. And this is really what we're hoping to sort of hone down a little bit with the work Juliette's doing. So how well do medications work? Shown here, we have lots of different medications. These are all studies, very high-quality studies, done looking at add-on medication versus placebo. And we can see here that all of these add-on medications did reduce seizure burden. But if we actually look at how well did they reduce seizure burden, we see maybe 30 to 40%. If you're having 100 seizures a day, now you're having maybe 60 seizures a day. Is that a big difference in your quality of life? I hope that we can do better. So we see that from anti-seizure medications, we have lots of medicines that are available. We do have these medicines that reduce seizures, but again, the likelihood of seizure freedom is very low, and most patients are still having multiple daily seizures. That is still a problem. Well, how about our complementary therapies or other therapies, non-pharmacologic? So dietary therapies are things that we often consider early, particularly if the family is highly motivated. This has been looked at by John Freeman. This was a placebo-controlled study. They had 20 kids started on the ketogenic diet. Half of them were actually given glucose to break the ketosis, which didn't always work, so it was actually an active control. And then the other half got saccharin. And they did find that fasting was associated with a significant reduction in parent-reported drop seizures as well as EEG seizures. And then Monica Lemon did a retrospective review of 71 cases, showing at 6 months about 50% had a greater than 50% reduction, and about a quarter had a greater than 90% reduction. So again, I think meaningful help, but we don't really see too many seizure-free. Looking at resective surgery, again, in patients with LGS, this is a small number of patients who will actually qualify for this, but unifocal or unilateral lesions on MRI or evidence of unifocal or unilateral seizure onset. And importantly, in LGS, the EEG lies, and so you can't always use the EEG to exclude who is or is not a candidate. Looking at a meta-analysis of 4 studies, they found 76% experienced a reduction in seizure frequency. And in fact, they did have seizure-free rates ranging from 24 to 55%, and that's better than any other therapies we have. So for those patients who are candidates for resective surgery, this is really critical. This was a single-center experience from Korea, and they had a large number, 90 patients with LGS. They found in their study half were seizure-free, and you can see that patients who were seizure-free were more likely to have large resections, and that is something that we typically do see. And all of these patients, importantly, had both generalized slow spike wave and generalized paroxysmal fast activity on EEG before surgery, and seizures that looked generalized on EEG. But in addition, they also had clues to focal onset. And so pay attention to those more subtle clues. And here again, the most common pathology was malformations of cortical development or focal cortical dysplasia. Moving on to callosotomy. Callosotomy can sometimes be a significant, can have a significant impact on quality of life, and particularly for atonic or tonic seizures can be really important at reducing or even stopping this seizure type, less impactful for other seizure types. A meta-analysis looking at 19 studies of individuals undergoing corpus callosotomy showed that 3/4 had a reduction in seizure frequency. And for drop seizures, the reduction with callosotomy is higher than for VNS. Importantly, one of the concerns with callosotomy is this disconnection syndrome, and there's really very little evidence for any permanent disconnection syndrome in people with LGS. This was now a study from about 10 years ago, and it looked at children with LGS and compared those who continued on medical therapy versus those who underwent an anterior corpus callosotomy, and that was based on parent decision. And these kids were followed up for 5 years. And you can see the comparison of the surgery versus the medicine group. The blues are those who achieved seizure freedom. The red are greater than 50% reduction in seizures, and the yellow are those without significant change. And we can see here that over those 5-year periods, seizure control was significantly better in those who had undergone the corpus callosotomy versus those who continued on medication. And they looked at the different types of seizures, and again, you can see here that the biggest difference between those groups were in tonic or atonic seizures, the classic drop seizures, but there was also pretty nice reductions in tonic-clonic seizures. Additionally, they looked at quality of life and full-scale IQs 2 years out, and they found that those were higher in the surgical group. So callosotomy can make a difference. What's also recognized, and again, it's in a minority of patients who undergo callosotomy, is sometimes that can unmask focality, so it will allow you to go forward and do further surgery. This was a study looking at 39 LGS patients who had undergone a complete callosotomy, who had no evidence of focal lesions prior to callosotomy. And following that, in 7 of 39 patients, they actually were found to have a focal discharge. And that focal discharge then allowed the providers to go forward with a resective surgery. And of those, 5 of 7 had improved seizure control, including 4 who achieved seizure freedom. Well, let's move on to neuromodulation. So there have been several meta-analyses done looking at efficacy in Lennox-Gastaut syndrome, which actually shows efficacy is quite similar to other drug-resistant epilepsies. So about 50% will have significant benefit. Looking at the VNS Outcomes Registry, at 24 months, almost 58% were said to be responders with median seizure reduction of 64%. So that can also be, I think, very meaningful and helpful, although seizure freedom is exceedingly low. Other forms of neuromodulation are being studied. This is a study from Australia looking at deep brain stimulation of the centromedian nucleus. It was done predominantly in older adolescents and adults. And these patients had either 3 months of blinded sham stimulation versus real stimulation. They were small numbers of patients, and when they looked at the change in the diary recorded seizures by the parents, the sham stimulation is in gray, the real stimulation is in blue, and you can see there was a reduction in seizures, but that reduction was not significant. They also looked at EEG recorded seizures, and there was a significant reduction. Despite the very small number of patients, there was a significant reduction in seizures. Importantly, this did not show any improvement in quality of life, although there was an improvement in epilepsy severity. Well, how about comorbidities? So Tracy has already alluded to this survey done in 2018 by caregivers through the LGS Foundation. The biggest concern for caregivers is still seizures and safety. But we see LGS is about much, much more than just seizures. So a lot of patients have issues with feeding, with mobility, with sleep, with behavior, with cognition. And so very many other concerns, and Dr. Valente will address some of these tomorrow. So how about standard of care for screening and diagnosing comorbidities? Over 90% of caregivers, and I'm surprised it was just that, not 100%, agree that measuring behavior, communication, and quality of life is really important. But fewer than half actually felt the healthcare provider evaluated these well, and that's because it's really, really difficult to do that, right? We need better ways of assessing that, and we're going to hear about that tomorrow. Well, how well do our therapies address comorbidities? Looking at anti-seizure medications, there's actually pretty limited data from randomized placebo-controlled drug studies regarding cognition, behavior, and sleep. The ones that have been done more recently actually do measure a little bit more, but some of those older studies, there's very, very little in there. The Become study was a study that was done looking at caregivers of patients with LGS and Dravet syndrome. They included patients who were on CBD for longer than 3 months, and they assessed non-seizure domains, whether those were improved or not. Now, this study had a number of methodological concerns. So you had recall bias. You had to remember what life was like before starting CBD and compare. It was also unblinded. And importantly, it selected maybe patients who were going to respond better to CBD, right? Because you had to be on that for 3 months to get into the study. But what was important is that this medication did show improvement in physical functioning, sleep, ADLs, language and communication, emotional function, and importantly, alertness, cognition, and executive function. And these changes were most profound in patients who had had a greater seizure reduction, but were also seen in patients with less robust seizure reductions. And so this is, I think, a really important thing. We want to do this not retrospectively like the study does, but we like to do this prospectively. Looking at resective surgery, this is the same study that I showed you from Korea, and they looked at the social quotient in persons with Lennox-Gastaut undergoing resective surgery. And what they found was that patients who were seizure-free actually did better than those who were not seizure-free. And importantly, with increased time, the differences became more profound. So the importance of jumping in and doing surgery early. In addition, they found that the longer the lag from seizure onset to surgery, the poorer that social quotient was. So we want to be identifying these patients very early and getting them in. That means seeing patients very, very early, ideally in that time of evolution to LGS. Looking at the impact of callosotomy and neuromodulation on the non-seizure outcomes. In callosotomy, 8 studies and 4 suggested no significant change in cognition or behavior. 1 study suggested some improved alertness, 2 suggested some improved cognition, and 1 suggested improved behavior. But importantly, quality of life improved in the majority, and I think just because if we can really impact those drop seizures, that has a huge impact on quality of life, not for just the child, but also their family. For VNS, it's a bit of a mixed bag. So 5 studies reported improved alertness, 2 suggested some improved quality of life, 4 showed no significant change. And I've already talked to you about the DBS, so no significant improvement in cognition or adaptive behavior. The challenge is, however, that the toolkit they used for measuring adaptive behavior was not one that could be done by most participants. So I think that needs further work. So let's look at our state-of-the-art for managing comorbidities. So for cognitive delays and autism, and that impacts certainly almost all patients with LGS, we involve PT, OT, and speech early. We involve our neuropsychology or developmental pediatrics colleagues, ideally before school entry, so the school is ready for these kids. We make sure that the family has liaised with the school, so the child has a 504 plan, the child has an IEP plan in place before they get into the school. And if the patient does meet criteria for autism, we advocate strongly for ABA therapy. For behavior, we have a number of medications in our back pocket, but these are often exhausted pretty quickly. And so we often are looking for psychiatry and psychology to help out, but it's often really, really challenging to find individuals who have the expertise and interest in that. There are no evidence-based guidelines for which medications to use. For agitation and aggression, some medications can be used, but again, have not been studied in any standardized way. For sleep, we know that sleep medicine and trying polysomnograms can be helpful to evaluate sleep. It's often very challenging for kids with LGS to undergo polysomnography. We have some medications that we can use to help with sleep: melatonin, clonidine, trazodone, gabapentin. Again, no evidence base for that. And we always talk to families about sleep hygiene, but families are generally doing a pretty good job of that even before we talk to them. For SUDEP, we know that's a significant risk also in LGS, and again, we want to optimize seizure control. That's the best, the best of our ability to try and reduce that, but we are limited by what we have available. And we discuss nocturnal monitoring devices. Many families use this, but again, no evidence base. And then really importantly, as we've heard, the stress on families is incredible, and we want to make sure that families are connected and supported. So advocating for respite care, making sure our caregivers are getting cared for themselves. So what have we achieved? We have clear diagnostic criteria for LGS, right? So that's good. We can compare apples to apples. The challenge is it takes time to evolve to that. We have some potential biomarkers, but these are pretty weak predictors. We have lots of different therapeutic options with demonstrated seizure reduction. We understand resective surgery in the minority of patients who are candidates should be done early. And we understand the significant impact that comorbidities have on quality of life for patients and caregivers. What do we actually need to learn? We need robust and highly predictive biomarkers, not like tossing a coin. We need highly predictive ones to tell us who will go on to Lennox-Gastaut. And once we identify that, we need to be able to intervene successfully. We need therapies that will help prevent that from occurring. We have highly effective therapies, we don't have highly effective therapies. That's what we need to result in robust seizure reduction. And we need to understand how we utilize the ones that we have, how we combine those, how we select for that patient with LGS and a certain seizure type and specific comorbidities, what is the best. Remember that all patients with LGS have not only LGS but an etiology, and probably that etiology is going to be really important for selecting best therapies. And I think we need improved recognition of comorbidities, sort of like the TAND, or that's in tuberous sclerosis-associated neuropsychiatric disorders, a checklist. We need something like that for LGS, and we need better ways to treat these comorbidities. So thank you very much.